Greetings and thank you for joining us for this webinar on identifying and addressing elevated sodium intake to decrease cardiovascular risk, expert perspectives and discussions. My name is Virend K. I'm a cardiologist at the Mayo Clinic, and I will be joined by two outstanding colleagues, Dr. Deborah Clegg, who is the Vice President for Research and Professor of Internal Medicine at Texas Tech University in El Paso, Texas, and Dr. Greg Pressman, who is the Director of Academics in the Division of Cardiology at Einstein Medical Center in Philadelphia and Professor of Medicine at Thomas Jefferson University. So the agenda today is to talk on salt, sleep, and cardiovascular risk, and that will be done by myself. This will be followed by hypertension and beyond, the impact of sodium across the cardiovascular disease spectrum, which will be covered by Dr. Greg Pressman. And then Dr. Deborah Clegg will cover practical strategies to address the impact of increased sodium consumption on cardiovascular risk. Now, I'm going to start off on my topic, which is salt, sleep, and how these relate to increased cardiovascular risk. We'll cover four different areas. First, we'll talk about salt and its relationship to blood pressure. Then talk about salt intake in terms of diets and drugs. How much salt is in our diet and in some of the drugs we take, and what is the consequence of that? And then talk about sleep disorders and cardiovascular disease in general, setting the stage, then cover how narcolepsy is linked to cardiovascular disease and how high salt intake in people with narcolepsy may in fact be a relatively unrecognized problem. So first, salt and blood pressure. What do we know? Well, increased salt intake is consistently associated with sustained increases in both plasma volume and blood volume. And the increased salt intake may be accompanied by a reduced ability in some people of the kidney to excrete sodium. So when the capacity of the kidneys to maintain sodium balance and extracellular fluid volume within the appropriate range is compromised, you get increases in blood pressure. Now, this increase in blood pressure is important to restore excretion of salt and water. This is called pressure natriuresis, and this is one of the body's homeostatic mechanisms by which it deals with a high intake of salt. The salt increases the blood volume increases the blood pressure, that increases the pressure natriuresis in the kidney, and that seeks to restore the homeostatic balance. Now, what about salt sensitivity? What does salt sensitivity mean? Now, the problem with salt sensitivity is some people can effectively excrete high dietary salt intake without any increase in blood pressure. And other people, whom we term salt sensitive, need a higher blood pressure to excrete the sodium effectively. And this is a very heterogeneous characteristic with a familial component. People who tend to be salt sensitive or have a higher risk of salt sensitivity include women, African Americans, postmenopausal women, and older people. In fact, 73% of Black hypertensives are salt sensitive versus about half of white hypertensives. So you see, salt sensitivity is fairly common. It's linked to certain specific characteristics, and we have hypertensive people. The fact that they're hypertensive automatically makes them likely to be salt sensitive. And so if they fit any of the criteria of being African American or woman, postmenopausal or older age, that heightens the likelihood that they are less likely to be able to tolerate a salt load. Now, salt-sensitive hypertension is defined as an increase in blood pressure associated with an increase in salt intake. And about half of humans with hypertension have salt sensitivity. And as I mentioned, it varies based on sex, age, and race. Now, if you look at normotensive, about 1 in 4 normotensives are salt sensitive. And this salt sensitivity, even in a setting of normotension, this is important. Salt sensitivity even in the setting of a normal blood pressure, is associated with increased mortality, because high salt intake doesn't just affect your blood pressure. It also can cause tissue injury. And this is increasingly being recognized as a potential problem in people who take in lots of salt. End organ structure and function, it can be damaged by salt, and this may be the basis for the higher mortality in normotensive people with salt sensitivity. And last, in response to a high salt diet, as I mentioned before, your volume increases, cardiac output increases, and salt-resistant subjects respond with reciprocal decreases in systemic vascular resistance. So if you can handle salt, when your cardiac output goes up, your vascular resistance goes down to keep your blood pressure normal. But if you're salt sensitive, you have a paradoxical increase in that vascular resistance associated with an increase in blood pressure. Now, let's talk about salt intake in terms of diet and drugs. Now, this is going to be covered by my colleagues as well, but these are very important points. So we thought it would be appropriate to repeat some of this information. You'll hear it again from the other speakers. Let's think about drugs. Let's think about a commonly used drug, which is effervescent paracetamol. It's interesting that, and not just interesting, but also relatively unrecognized, that effervescent paracetamol has about 1,700 milligrams of salt and of sodium. And in oxybate, sodium oxybate, which is a drug used to treat narcolepsy, which I'll tell you more about shortly, it's a sleep disorder. Sodium oxybate has 1,640 milligrams of salt, about the same, of sodium. And the average US salt intake that's recommended is 3,400 milligrams. The average US salt intake is 3,400 milligrams, but what's recommended is 2,300 milligrams. So the message here is that it's recommended we take in 2,300 milligrams, but the average US dietary intake is 3,400 milligrams. And if on top of that, you're taking either sodium oxybate and or effervescent paracetamol, you're taking in huge amounts of sodium above and beyond what the recommended value is. So keep those issues in mind. Now, what is the consequence of sodium loading? First, 2,300 milligrams per day increase in sodium excretion is by the way, when we talk about sodium excretion, that's the way we measure how much sodium you took in. So it's a good measure of how much salt you consumed. If we measure it in the urine and tell you how much salt was in the urine, that reasonably well predicts how much salt you ate. Now, if you have a 2,300 milligram a day increase in sodium excretion, you get a 3 to 6 millimeters of mercury increase in systolic blood pressure. 24-hour systolic blood pressure increases by 3.5 millimeters of mercury with 3 weeks of effervescent paracetamol, which I told you had about 1,600 milligrams of sodium. And if you salt load at these doses, you will blunt your nocturnal blood pressure decline. You can then transition to becoming a non-dipper because your blood pressure will fall less at night. And being a non-dipper carries its own set of cardiovascular risks above and beyond just having hypertension. So keep those considerations in mind. Now, more on sodium loading. Sodium-containing medications have been associated with a much higher increased risk of adverse cardiovascular events. And if you're taking effervescent paracetamol and then you stop it 4 weeks after stopping it, your systolic blood pressure can be lower by 13 millimeters of mercury and diastolic by 2.5. And here's some epidemiologic projections saying that if you reduce your sodium intake by 1,200 milligrams a day, which incidentally is less than how much sodium is in effervescent paracetamol and less than how much sodium is in sodium oxybate, if you lower your sodium intake by that much a day, you will reduce your heart attack risk by 12%, stroke risk by 8%, and all-cause mortality by 4%. So we talked first about salt and blood pressure, and I explained what salt does to hemodynamics and how the hemodynamic response can differ in people who are salt sensitive versus salt resistant. Then we talk about dietary recommendations for salt intake and how certain drugs like effervescent paracetamol, like sodium oxybate, can have very substantial levels of sodium that can take you way above your recommended daily intake. Now let's talk about something somewhat different: sleep disorders and heart disease. And the reason we're going to talk about this is because we sometimes use high salt containing drugs to treat sleep disorders. And let's first understand what sleep disorders mean in terms of cardiovascular risk. Well, here's someone with obstructive sleep apnea. And this is measurements of sympathetic activity shown by these spikes, breathing, and intra-arterial blood pressure when the subject was awake. This is a newly diagnosed obstructive apnea, on no medications, never been treated. He goes to sleep, he's in REM sleep, and you see that blood pressure was 130/60 intra-arterially when he was awake. And when he was asleep, it's much, much higher, because these apneic events shown as OSA, they cause sympathetic vasoconstriction in response to the fall in oxygen levels and the rise in carbon dioxide. And that sympathetic vasoconstriction raises your blood pressure to levels of 240/130. And this patient is going to be a reverse dipper. You see, the blood pressure is 130/60 awake, but way higher during sleep, particularly in REM sleep. So blood pressure did not fall during sleep, it actually goes up, but you treat him with CPAP, and here he's in REM sleep, and his blood pressure is not perfect, but it's much better. So the message here is that sleep apnea, which is very common, is linked to higher sympathetic activity and higher blood pressure during sleep. And these high blood pressures and high sympathetic activity during sleep carry over into the daytime, so that sleep apnea patients have a higher risk of daytime hypertension. People with sleep apnea tend to have a 30 to 40 to 50% increased risk of developing incident hypertension over a period of 4 to 10 years observation. Now, what are the cardiovascular implications of obstructive sleep apnea? Well, you've got this hypoxemia and reoxygenation. You've got autonomic dysfunction, namely sympathetic activation, arousals, which also raise blood pressure and disrupt sleep, intrathoracic pressure changes, high CO2, and these act through these disease mechanisms to induce inflammation, endothelial dysfunction, increased coagulation, metabolic dysregulation, hemodynamic changes, left atrial enlargement, and sympathetic activation. And you get these cardiovascular disease consequences like high blood pressure, atrial fibrillation, heart failure, coronary artery disease, stroke, pulmonary hypertension, diabetes, and heightened mortality. Now, it's important to know this, because you can understand then that if you throw in high amounts of salt into this mix, you are going to exacerbate the risk of these cardiovascular disease conditions, particularly high blood pressure and high heart failure and stroke, in terms of their overall risk of occurrence. So we know that if you don't sleep a long time, if you have a short sleep duration, independent of sleep apnea, this is just not sleeping for a long period at night. If you sleep 5 hours or less a night, you're going to have a twofold increased risk in future hypertension. So the chance of, if you're normotensive today, but you're habitually sleeping 5 hours or less a night, your risk of hypertension down the road is doubled. Now, here's the Nurses' Health Study showing the effects of a short sleep duration. And you see sleep duration 5, 6, 7, 8. If you give 8 hours of sleep duration, a relative risk of 1 as a reference point, you see that as your sleep duration decreases to 7 to 6 to 5, you get an almost twofold increased risk of incident or new onset coronary artery disease. So if you have no coronary artery disease today, but you sleep 5 hours a night habitually over 10 years, you have a twofold increase in your risk of developing new onset coronary artery disease. So that's important to know, that if you have a sleep disorder like short sleep or obstructive sleep apnea, you have a higher risk of cardiovascular disease down the road. Now let's talk about narcolepsy. Narcolepsy is a chronic neurologic sleep disorder. There are 5 predominant symptoms: excessive daytime sleepiness, cataplexy, which is the equivalent of a falling episode. The narcoleptic can get into sleep, a REM sleep state, and fall to the ground. They have disrupted nighttime sleep, so sleep deprivation, sleep-related hallucinations, and sleep paralysis. The onset of symptoms typically occurs in childhood or adolescence, and this is the problem with narcolepsy. They have lots of comorbidities, independent of everything else. If you just look at patients with narcolepsy, they have a much higher risk of hypertension in the yellow bars compared to non-narcoleptics in the gray bars, of coronary atherosclerosis, congestive heart failure, and myocardial infarction. They also, very importantly, have a much greater risk of sleep apnea. So keep those things in mind. Now, narcolepsy is associated with cardiometabolic abnormalities, arterial hypertension, we talked about ischemic heart disease, abnormal lipids, high risk of diabetes, and a high risk of atrial fibrillation. And this shows some of the literature in terms of their risk of obesity, hypertension, diabetes, dyslipidemia, the odds ratio, the increase in risk in comparison to what's expected. You see a twofold higher risk of being obese, 30% increased risk of being hypertensive, almost twofold increased risk of diabetes, and a 50% higher risk of having hyperlipidemia. So narcoleptics seem to be cardiovascularly and metabolically at greater risk. And in fact, when you look at the BOND study, which was done a number of years ago, looking at the cross-sectional risk of narcoleptics, they have a higher likelihood of stroke, heart attacks, revascularization, heart failure, and cardiac arrest. So if we think about narcolepsy and mortality, mortality rates are also high in patients with versus without narcolepsy based on a longitudinal claims database compared to the general population. And people with narcolepsy had about 50% higher likelihood of death compared to those without narcolepsy. Now, this is the CV BOND study, which we recently completed. And here we looked at the incident likelihood of newly diagnosed cardiovascular renal conditions in people with narcolepsy versus matched non-narcolepsy controls. And the key findings you see here is any stroke, heart failure, ischemic stroke, MACE, stroke, atrial fibrillation or edema, and any CVD. All of these fall to the right of this line, which suggests that there's an increased risk in people with narcolepsy. So this was the CV BOND study following up on the BOND study, which showed a heightened cross-sectional risk. This is incident future risk, and we noted that the risk of cardiovascular events down the road is high in people with narcolepsy. Now, bearing in mind that sodium oxybate, which we talked about earlier, has about 1,600 milligrams of sodium, what happens if you give a narcoleptic sodium oxybate compared to a narcoleptic not receiving sodium oxybate? What happens to the hypertension risk? Well, these are data that were presented recently at the American College of Cardiology. Our preliminary findings addressing this question. We looked at incident or new onset hypertension based on either a diagnosis or giving somebody an antihypertensive drug. And looking at both of these, particularly if you combined a diagnosis of hypertension and initiation of antihypertensive therapy, we found a significantly higher risk of future hypertension over about 6 months of follow-up in people with narcolepsy. That's a fairly short follow-up period. So this seems to be a reasonably significant stimulus to developing new hypertension in narcoleptics, giving them a high salt load via sodium oxybate. Now, I'm going to conclude by going over some of the things we talked about. We reviewed how salt can raise blood pressure and how your response to a salt load can help determine if you are salt sensitive or salt resistant. The salt sensitive people we need to worry about because they raise their blood pressure significantly at a heightened risk for problems from salt intake. Bear in mind that diets contain a very high amount of salt in the US, much higher than what we're supposed to take, and that when you add drugs like effervescent paracetamol and sodium oxybate or other sodium-containing drugs on top of that, you're going to get a much greater effect of salt consumption. that sleep disorders, obstructive sleep apnea, short sleep, narcolepsy are accompanied by a higher risk of cardiovascular disease. And when we look at narcolepsy itself, narcolepsy is just independent of everything else, linked to a high likelihood of poor cardiovascular outcomes. It's also linked to a high likelihood of sleep apnea. So if you have a narcoleptic, he or she is much more likely to have obstructive sleep apnea, which puts them into this third panel here, the higher risk of CV disease with sleep disorders. And if you start giving narcoleptics drugs that contain high amounts of salt, like sodium oxybate, you are likely to increase their future risk of hypertension and more than likely other cardiovascular diseases.